Hello and welcome to SRG's Medicine. Today, in this video of Respiratory Medicine Series, we shall be concluding our talks on hemoptysis. So, the contents of this video are aims of treatment, algorithm for non-massive hemoptysis, treating massive hemoptysis, and algorithm for massive hemoptysis, and then ultimately concluding the video by summary. So, what are the aims of treatment of hemoptysis? If hemoptysis is non-massive, then the aim of treatment is working out for the cause and treating it. Whereas if it is massive, then we have different objectives. The first one being protection of non-hemoptytic lungs, second one being location of the site of bleeding, then controlling the bleeding. And these all come under stabilizing of vitals, along with continuous management of vitals. And the final one would be work out for the cause of hemoptysis and then treating the cause. So moving on to the algorithm for non-massive hemoptysis. So if the hemoptysis is non-massive, then we first confirm whether it is actually hemoptysis or some other condition which is manifesting as hemoptysis. For example, it might be hematemesis or bleeding through oral mucosa, nasal mucosa, or pharynx. So firstly, confirming hemoptysis. After that, we'll move on to history taking. And after taking history, we'll start with physical examination, and then once we have our differential diagnosis list, we do appropriate lab and imaging tests for the suspected condition or for the differential diagnosis so as to confirm a single diagnosis. And after that, we have a confirmed diagnosis, then we treat the cause. So that is an algorithm for non-massive hemoptysis. Now, talking about massive hemoptysis. So how do we treat massive hemoptysis? So the first thing would be protection of the non-hemoptytic lung. How do we do it? Let's see. Firstly, we make the patient sit upright, or if we know which of the lung is bleeding or which side of the lung is bleeding, then we make the bleeding side of the lung downwards. And after that, the gravity will pull the blood downwards or towards the bleeding lung once we place the person with the bleeding lung downwards. Now, that will cause the blood to accumulate on the bleeding lung, but not on the non-bleeding lung. So when blood doesn't accumulate on the non-bleeding lung, that will cause no blockage on the non-bleeding lungs airway. So if there is no blockage in the non-bleeding lungs airway, then we can maintain adequate ventilation, whether that can be naturally or by single or double lumen bronchoscope or endotracheal tube. Here, the thing that we have to remember is that if we are using single lumen bronchoscope or endotracheal tube, then we have to intubate the non-bleeding lungs for maintaining ventilation. Whereas double lumen can be used for maintaining ventilation on the non-bleeding lung and performing interventional procedures on the bleeding. So the next step would be localizing the site of bleeding. And for doing it, we have a treatment algorithm. A diagnosing algorithm. That is, firstly, once we perform chest X-ray, then we get two things. That is, either we know which side of the lung is bleeding or what is the source of bleeding exactly, or we don't know the bleeding source. So either that shows chest X-ray shows the source of bleeding or there is unknown bleeding source. So if we know the bleeding source, then we perform bronchoscopy under general anesthesia, which serves us both diagnostic as well as treatment procedure or help. Whereas if we do not know the bleeding source, then it is not good to perform bronchoscopy, because here we have a 50% chance of looking towards the bleeding lung, because there are two lungs, and when we intubate on one lung to see, when we put the bronchoscope on one lung to see where the bleeding occurs, then there's 50% chance that the intubated lung, which we have intubated, might be the bleeding lung. So this chance game is not to be taken in a massive hemoptysis. Rather than that, we move straight on towards CT angiography because it helps both in diagnosis as well as in treatment. So the next thing would be controlling of bleeding. So for controlling bleeding, we can do either medical management or surgical management. So the medical management would be the use of antifibrinolytic drugs such as tranexamic acid or vasopressin precursors such as telepressin, which may help because here the clinical evidence of the use of antifibrinolytic or vasopressin precursors on hemoptysis patient are not well recorded till now. So they may help based on their use and action on other bleeding conditions. Whereas on surgical pathway or surgical management, we have three ways through which we can perform a treatment of the massive hemoptysis or controlling of bleeding. So the first one would be from the airway lumen. From airway lumen, we can perform flexible bronchoscopy, but it is only a temporary method because through it we can only suction the clot and insert balloon catheter, which will stop the bleeding for the certain time being till we have the balloon catheter on. But we have another way, that is use of rigid bronchoscopy, and that's done by the interventional pulmonologist or by thoracic surgeon, and it is more or less permanent one. Because through the help of rigid bronchoscopy, we can perform photo or thermocoagulation, or we could perform electrocauterization. So that is by the use of light, heat, or by the use of electrical spark, we close off the bleeding artery. So that is more appropriate and because it's more permanent. After that, we could control the bleeding not only through the airways, but also from the blood vessel pathway. So how do we do it is through the blood vessel pathway, we can insert a catheter, and through the catheter, we can perform bronchial artery embolization. And here we have a risk of the embolization of anterior spinal artery. This anterior spinal artery supplies the spinal cord. So we might have a risk of various neurological signs and symptoms there, but the risk is quite slim one. So it is also a common way of controlling bleeding. The other one is surgical resection of both airway and the vessels involved. It is a highly risky one. So it's a highly risky procedure, so it is not commonly preferred. So there is a high mortality of 5 to 40%, and it is only done in patient in whom the previous methods have failed and the patient is still bleeding out. And the ideal candidates for this kind of intervention is the candidates having localized disease, but otherwise normal lung parenchyma. For example, when we see in the case of solitary pulmonary nodule or neoplasm, or also in the cases of solitary tuberculous cavitations. So in such patients, this is quite ideal process, but it is not performed regularly because it is highly fatal. So now talking about the algorithm for management of massive hemoptysis. So once we have a patient with massive hemoptysis, we protect the non-hemoptytic lung, and after protecting the non-hemoptytic lung, we localize the site of bleeding. And once we know the site of bleeding, we control the bleeding. And during all these procedures, so when we perform all these procedures, during that time, we have to perform continuous monitoring of vitals, electrolytes, and oxygenation via the use of different methods, that is via the use of ECG, via the use of electrolyte panel, arterial blood gas analysis, or also via pulse oximetry. So there are many methods of doing it. And after doing that, if there is any kind of imbalance, then we have to maintain it. So we have to maintain the vitals, we have to maintain electrolytes and oxygenation within the normally acceptable range. Here I've mentioned normally acceptable range because in a bleeding patient, so this is in an emergency setting, we should not focus on taking the levels back to straight on normal. We should take it towards the acceptable range, because if we just focus on taking the levels towards normal, our other process, that is towards controlling of bleeding, might be hampered. So we have to take it within the acceptable range only. So after that, after doing all of these things, now we'll perform appropriate history taking, examination, and the tests for suspected cause. Once we know our cause, then we treat the cause. So that's how we treat massive hemoptysis. So now talking about few general tips of this whole video series on hemoptysis. The first one is endotracheal intubation should be avoided unless it is necessary, as suctioning through an endotracheal tube is less effective means of removing blood and clot than by cough reflex, because cough reflex is more effective in removing blood and clots rather than endotracheal suctioning. And the next thing is that while using single lumen bronchoscope, we must intubate the non-bleeding lungs for ventilation. And the temporary methods such as flexible bronchoscopy or medical management such as by the use of tranexamic acid or terlipressin, they are not quite useful on a long-term basis because bleeding can reoccur. However, it is useful, rather we could say it is quite important in the cases of acute bleeding to control a bleeding for a given time till we could perform other permanent methods. So the summary of this video is: for non-massive hemoptysis, we aim to treat the cause itself. But for the case of massive hemoptysis, we first stabilize the vitals, followed by the treatment of cause. And the treatment of massive hemoptysis includes the following steps. First one, protection of non-hemoptytic lung. Second, localization of the site of bleeding. Third, controlling of the bleeding. And fourth, finding the cause of hemoptysis and treating the cause. Hope you have enjoyed the video till now. Please do comment your feedback and any questions that you have on hemoptysis. So by the end of this video, we are concluding our talk on hemoptysis. Hope you're enjoying it till now. Thank you.